issue that's obviously hugely important to everybody, addressing the high cost of prescription drugs. We both have very similar proposals that we believe would help protect consumers and increase accountability for drug manufacturers. I think most people know Massachusetts has the lowest rate of uninsured individuals in the country, but we continue to be an expensive state when it comes to the cost of healthcare. We have a long record of passing bipartisan healthcare reform legislation dating back to governors back in the 90s. In fact, it's been about 15 years since Republican Governor Mitt Romney worked with the Democratic legislature to pass the sweeping healthcare reform that assured virtually universal coverage here in the Commonwealth. In the fall of 2019, our administration filed comprehensive healthcare legislation to help address the rising costs of healthcare, including measures to address rising prescription drug costs. And in January of this past year, I signed a multifaceted bill that contained many of the priorities that we included in that original bill, including coverage of telehealth services, which became an even more pressing issue throughout the course of the COVID-19 pandemic. And while this bill included many critical provisions that will make a big difference for consumers, it didn't ultimately include our prescription drug pricing proposal, so we refiled it again this year as part of our budget proposal. It is currently before the legislature. I think far too often there are very significant increases in the price of critical drugs, which ultimately harm patients that rely on these treatments and increase costs to the system at large. We've already taken significant steps to control the drug costs in our state's Medicaid program, Mass Health, by passing a measure in our fiscal 20 budget that allowed our program to directly negotiate drug pricing with manufacturers and engage in a public process when a deal couldn't be reached. To date, we've successfully completed negotiations with 13 manufacturers on 36 different drugs, which have represented about $100 million in additional annual supplemental rebates here in Massachusetts, and there are additional drugs and products that are in various stages of negotiation. The current proposal we have before the legislature would increase accountability for drug manufacturers whose prices increase exponentially. The proposal would impose a penalty of the drug price increase greater than the consumer price index, which is inflation basically, plus 2%, which is what we would then refer to as an excessive price increase. This will obviously help people plan from one year to the next. It will also help limit the growth in drug prices to a more affordable level. And I'm hopeful that it'll be able to work with our colleagues in the legislature to get this measure done this year as part of our legislative session. Healthcare reform has been and continues to be a bipartisan issue, and we're thrilled to be here today to discuss this important idea with our colleagues from Connecticut. And I think Governor Lamont thinks this is, in fact, a very interesting way for states to engage in this conversation and perhaps establish a template that could be adopted by others. And with that, I will turn it over to Governor Lamont.
Well, good morning, and thank you, Governor Baker. I got to say it's been a privilege. Charlie and I have been working together very closely, especially in the last year during COVID, knowing full well that we're not different states. We are part of a region when it comes to that pandemic, and we learned a lot over this year. If I learned anything, I was reminded that healthcare is not just a basic right for you. It's a basic right for all of us. And if you don't get vaccinated, if you don't get tested, if you can't get that primary care, if you can't get the hospitalization, it can impact your life and it can impact those around you, which is why what we're doing now to make healthcare more accessible and affordable for everybody is so particularly important. Look, most of what I've seen in the reforms coming out of Washington and our legislature is sort of a question about who pays and how we can provide, more subsidies on the exchange, for which we're very thankful as the American Rescue Plan made the exchange much more affordable for now, middle-class people and above, to make healthcare more accessible to everybody. As Charlie mentioned, over this last year, we've done our best to make healthcare more accessible, the testing, the vaccinations at no cost, telehealth, and making sure that we can bring healthcare to you, and you can't necessarily come to us. But what we've got to do now, and where I think Massachusetts has taken the lead for some time, is what we can do not just to make it make healthcare more affordable, but also make sure you can afford to use it, and make sure that we can bring down the underlying costs of healthcare. So again, following Massachusetts' lead, we put in place a global benchmark, which provides a lot more transparency when it comes to hospitalizations, since hospitalizations and pharmaceuticals are two of the big drivers in terms of healthcare costs. And what a difference that's going to make, and that's made a difference in Massachusetts as well. In addition, we're moving towards preferred networks or centers of excellence, starting with our state employees, so that they're incented to go to those facilities where you get the best value in terms of quality and in terms of cost. Again, doing everything we can to bring down the high cost of health care for individuals, working families, and state budgets, to be blunt about it. And the next big driver in terms of healthcare costs is pharmaceutical costs. And that's why, you know, working with Massachusetts, I think this is the beginning of something that's incredibly important. Pharmaceutical costs represent somewhere in the area of 20% or so of our overall costs. And we wanted to put in place a mechanism where we did not discourage innovation in any way, but as you're going to hear from Caroline and Jay, also wanted to make sure that there were no surprises. And once you've got your set price for that drug, it can only go up at a function of inflation plus a little bit. That allows states to plan, that allows individuals to plan, make sure that we know what our costs are going to be going forward. And I'd like to think, Charlie, that over a long period of time, it's going to bring down the high price of pharmaceuticals for us all. So this is an example of how our different states are working together as one. I hope to make a difference for families across our region.
Hello, and thank you for being here today. My name is Carolina Chorvath. I'm a Boston-based journalist, and since the age of 10, I've also been living with Crohn's disease. When I was first diagnosed with Crohn's, I spent years at different hospitals and went through an array of tests to try and pinpoint the source of my symptoms. In 2015, I was diagnosed with a flare, or re-diagnosed with Crohn's disease. And after that, my life would never be the same. Something no one tells you when you're diagnosed with chronic illnesses like Crohn's is that if you're fortunate enough to find a viable treatment option, you may not even be able to pay for it at all. I will never forget the day I received a bill for my chemotherapy treatment. It was for $100,000. The number hit me in the chest. How could anyone afford that? I keep that bill as a reminder that the prescription drug pricing system is broken. Every diagnosis anniversary, the reminder of needing to fight so desperately for the medication that I need to live comes crashing down like an anvil. Like so many others, I live at the mercy of drug corporations. I already have to deal with the excruciating pain and uncertainty of living with multiple chronic conditions. I, and no one else, should have to face unaffordable drugs that we need to live. And I'm a privileged white woman. I have health insurance that allows me to afford my medications, but I still live in fear of losing that insurance coverage or my medications disappearing. It is unacceptable to leave any patient wondering if they can afford to live. The system is inhumane, and it's time for that to change. That is why reforms like these proposed by Governors Lamont and Baker are so important. They take on high prices set by big pharma and bring some relief to patients like me. Hopefully this is just the beginning. Thank you.
Good morning. Thank you for being here. My name is Jay Geronimi, and I live in Groton, Connecticut. When I was 9 months old, I was diagnosed with cystic fibrosis, often called CF for short. CF affects the lungs and digestive system, making it hard to breathe and eat without treatment. In the mid-'80s, when I was diagnosed, it was predicted that about half of people born with CF would die before the age of 28. Growing up, I had to take pills just to be able to eat, and for the first 12 years of my life, the only treatment for my lungs was to physically shake the mucus off them. Treatment for CF changed drastically in the early 90s with Pulmozyme, a prescription drug that helps thin out mucus and allows CF patients to breathe easier. The innovation was miraculous for me, but also very expensive at $1,000 each month. I was lucky because with my parents' insurance, we were able to afford the medication and I was able to breathe. But it began a lifelong quest to afford my prescriptions. I have since spent my entire adult life trying to find ways to afford Pulmozyme and a variety of other medications, like currently on 10. I've spent years jumping through hoops to afford my drugs, whether on insurance or not. In fact, in 2008, my insurance lapsed. The price of Pulmozyme had gone up to $1,900, and I was coughing up blood, so I desperately needed that prescription. My only choice was to max out my credit card. Recently, I started on a medication that makes Pulmozyme look cheap. Trikafta, which treats nearly all of my symptoms, has a yearly list price of about $300,000. That's on top of the cost of the pills I take to help me digest food, the various inhaled medications I have to take, and the insulin I now need due to diabetes caused by my CF. The ever-rising prices of these medications on top of my Trikafta terrify me. I'm lucky right now. I have a job that provides me with good insurance coverage. But I know that could change at any minute. It's not easy to work full-time when you can't breathe. I live in fear of the day I have to face the $32,000 fee it cost me to stay alive for a single month. I do not have that money. Even if I maxed out my credit cards, I'd only get halfway there. I shouldn't have to constantly live in fear of what would happen if I had to face the full price of my medicine. I shouldn't be forced to decide between financial ruin and detrimental health outcomes. It's why we need reforms. I'm grateful to Governors Lamont and Baker for moving forward proposals to take on the high and ever-rising drug prices that make life harder for patients like me. Their plans could quite literally make me breathe easier. Thank you.
Jay and Carolina, thank you very much. We'll now open it up to questions. So for reporters, if you could please use the hand raise function. Keep in mind, we also have Lauren Peters from the Baker administration. We also have Vicki Veltri from the Connecticut Office of Health Strategy. So use the hand raise function. We could try to get to a couple of questions. We'll start with Jessica Bartlett.
Thank you so much. I had a question about the penalty. So you have capped the annual rise in prescription drug costs. What is the penalty if manufacturers go above that? And will this be on every drug that is made available to patients in both of your states, or does it have a limit of the drugs it applies to?
Lauren, you want to take a crack at that?
Sure. Thank you for the question. So the penalty is equal to 80% of the increase amount in excess of CPI plus 2%. So it's really the delta between the actual price increase and CPI plus 2% in a given year. And it's on a per unit basis of drugs that are sold or distributed here in the Commonwealth. And this does apply to both generic and brand drugs.
And I guess I'll take a shot in Connecticut. This is Vicki Veltri, and we have the same penalty, same structure, and it applies to the same drugs.
Thank you.
Julia Bergman.
Can I just add a little exclamation? It's worth remembering that, roughly 75 to 80%, sometimes up to 85% of all the prescriptions that get filled in the United States are generics. And generics, by definition, are drugs that have been in the market for a very long time and are drugs for which all of the issues associated with what we would call the big spend on research and development is done. And significant increases in generics, which we have seen at various points in time over the course of the past 10 years, have huge consequences for basically almost everyone who fills a prescription for any of those pharmaceuticals. And in this particular case, it seems to me that this is a perfectly appropriate way of sending a message that says, if you want to spend significant resources on R&D to chase really hard to solve problems, by all means. But to have the kind of circumstance and situation we have had at many points in the past 10 years, where the year-over-year increase in generics has gone up 20 or 30 or 40%, that just shouldn't happen. And in some ways, I think part of this is about making sure that at least for those and for some of the branded drugs that have been in the market for a long time, there should be predictability for people who need these medications.
Julia Bergman.
Thanks. I have a question for Governor Lamont. The head of Boehringer Ingelheim's research team in Connecticut recently penned an op-ed saying your proposal will impede scientific advancement. She said the company reinvests more than 20% of its net sales into research and development, and that the proposal would negatively impact those investments. She also points out that prices set by a pharmaceutical company often have little to do with the amount paid by the patient, which is typically controlled by a patient's health insurance plan. So can you respond to her comments?
Yeah, no, we've had good conversation, Boehringer Ingelheim, but as Charlie, explained, I think, really well, all those innovation investment costs are baked into the original price of the drug. And all we're doing is capping the increase going forward. So Boehringer and all the other great pharmaceutical companies won't have any less incentive to go forward and continue to make those investments. But, thankfully, Carolina and Jay are going to at least have some certainty in terms of what the price is going to be the next year.
Regarding the second question, I will chime in and say the list price does affect the price paid at the counter. There's significant research that shows what the list price is by a pharmaceutical manufacturer affects not just the acquisition cost by the pharmacy, but also what the patient pays at the counter, which often depends on, the list price of the drug. So if they have a co-insurance or a copay, or if they're uninsured, they're going to be paying a percentage of the list price at the counter.
The other point I would make with respect to this issue is there is sort of a standard practice in pharmaceutical pricing and negotiations that involve rebates, and I don't have a problem with that, but it is possible for people to use that list price as a mechanism to drive a particular actual price paid by the insurance carrier, by the individual buying the copay or the coinsurance on the drug. And I think in some ways, if you have a mechanism in place to deal with the list price, then some of the stuff that goes on with respect to the rebates gets a lot clearer and a lot easier. And that does flow through ultimately to what the insurance company is paying for the medicine and for what the insured individual or the uninsured individual is paying for that medicine as well.
Shira Schonberg.
Thank you. I guess two questions. The first is, could this policy potentially incentivize drug makers to price drugs high initially, since there's no curb on the base price, but only on the growth? And then secondly, is there a mechanism in these policies to make sure that the lower prices actually trickle down to consumers rather than being swallowed by PBMs or insurers?
I think both states have proposals in place to create a more transparent process for the so-called middleman in this process, the PBMs, which I think would be a good way for us to make sure that the benefit associated with this isn't lost at the ultimate point at which a consumer has to purchase their prescriptions or fill them. The other thing I would say about that is if you have a structure in place that deals with the vast majority of the drugs that are being purchased every single year, that establishes some structure around what's going to happen with respect to the price across 85 to 95% of all the drugs that are out there. I think that does have a positive impact ultimately on the total cost of healthcare, what people pay for insurance premiums and what people pay at the point they actually fill that prescription. What was the other part of that question, Shira?
It was just about, could it incentivize drug makers to price drugs high initially, since there's no curb on the base price, just on the growth?
Well, in the end, when I think we all know that when people go through the process of determining what the so-called price is coming out of the gate, that is very much a function of many elements. I don't see how this one would matter that much, given that we're talking for the most part about stuff that will have already been in the market and will have had sort of a, sort of an established baseline on which to begin. And as I said in my previous comments, the vast majority of the prescriptions that get filled, the vast majority of the prescriptions that make up a big piece of everybody's health insurance costs, and the vast majority of the prescriptions that determine what people pay through their copay or if they're uninsured, what they pay for the drug, even if they're enrolled in one of the discount programs. All of those are ultimately going to benefit from a proposal like this, which will take some of the run rate out of drugs that ultimately really ought not to have big year-over-year increases.
Steve Singer.
Thank you. Is there anything on the federal level, either with ACA or prescription drug legislation during the administration of President George W. Bush, I think 2005, 2006, that addresses this?
Steve, my understanding is there are a number of federal bills along these lines that are being considered. One is just capping drug increases at just the rate of inflation. We're at a rate of inflation plus 2%. So we're taking the lead, but we'll see where the feds end up.
But is there anything that has been done over the years? I guess not if you're doing it, but I'm just wondering if there's anything on the federal level that addresses this issue that's already in statute or done administratively by HHS.
I'm not aware of anything. Lauren, are you aware of anything?
No, I'm not aware of any structure like this, being a penalty on price increases.
Okay, thank you.
Hartford Business Journal.
Hi, yes. Bioscience is one of the few growing industries in both Massachusetts and Connecticut. Do you have any concerns that this may impact the growth of these industries, setting a template for other states on drug prices?
I think most of the work that's being done in the biotech space is critically important, not just because they provide a lot of jobs, but because they solve a lot of problems, many of which are enormously complicated and difficult and challenging to solve. And, the success of this country's biotech and pharma industry in producing vaccines in an incredibly short period of time that are enormously effective once they were given the genome profile of COVID-19 is, honestly, it's a miracle. But that is a lot different than the issue we're talking about here, which is a market in which the vast majority of the products that get sold every single day have been on the market for years, in many cases, decades. And why there would be this issue and problem continuing year after year after year with these products seeing very significant increases in their list price that go way beyond anything that looks like inflation, just flies in the face of what I would describe as sort of common sense. And I think from our point of view, companies should be able to significantly invest and significantly get a return for the work that they do to solve really complicated and difficult and challenging problems. But at the same time, I think it's important, especially when you're talking about medications that in many cases have been around for a really long time, that there be some mechanism that establishes some kind of control mechanism to deal with the increase in prices associated with those. Because at the end of the day, you're also hitting the vast majority of the people who fill prescriptions when you're talking about those medications too.
And just to chime in on Governor Baker's comment, I mean, classic example is the EpiPen, right? That was invented years and years ago, but the prices kept going up. It went up at least 6 times in a 9-year period and has been around for a long time. What's the rationale behind a drug like that that's been around for forever and serves a really important need to be going up at prices that exceed inflation year after year?
The Waterbury Republican American.
Thanks. I was wondering, Governor Lamont, if you could answer some of the criticisms that I'm seeing in the testimony on this bill. You had opponents from drug makers, biopharmaceutical companies, the Connecticut Citizen Action Group. There's a lot in there about it not lowering drug costs for what people pay at the pharmacy counter, doesn't account for subsidies in the American Rescue Plan, fails to offer any assistance for small business, works counter to economic development goals, undermines innovation at a time when it's most needed. I'm sure you've heard these.
Message. Look, here's the deal. Some people say it goes too far. Some people say it doesn't go far enough. But I think, as Charlie's explained, this is a very thoughtful bill that makes good sense. If you're a drug producer, all your innovation, your risk, your investment up front is going to be priced into this. Nothing's going to discourage ongoing innovation going forward. And both Massachusetts and Connecticut welcome that innovation here, within our states. What it does do is it takes that surprise billing out of the mix going forward. As Charlie said, a lot of these drugs have been out there in the market for 10, 20 plus years. They've paid for that investment risk many times over. There's no need for them to have more than a rate of inflation and a couple of percent over and above that to continue to earn a decent rate of return.
And also, how do you answer the criticism over the annual assessment of $50 million on all large commercial group plans? That seems to be another objection.
Yeah, well, that's a very different issue. But, Charlie, what we've done is they've got that federal tax that they got rid of, and 85% of that cut is going to go to the insurance companies. About 10 to 15% we're keeping. It represents something like $50 million. And what Connecticut's doing with that is going to make sure that all your work on the exchange and other insurance is more affordable. Right now, the American Rescue Plan is subsidizing what you have to pay in terms of monthly insurance premiums, but you still can have a big increase. You can still have co-pays and big deductibles that make it unaffordable for you to go to the doctor. What we're going to do with our share of that $50 million, is make sure that we limit the co-pays and deductibles, make it easier for you to be able to afford to go see your doctor.
Okay, thanks very much.
The Associated Press.
Thanks, Max. Good morning, everyone. Is there a particular benefit for Connecticut and Massachusetts residents by having the same drug pricing legislation passed in both states?
I don't think that wasn't what prompted us to pursue this or to engage in a discussion with Governor Lamont and his team about this. I think it was more that Governor Lamont and I were talking about a variety of issues around COVID, which obviously we've been discussing quite a bit over the course of the past year. And in that conversation, we ended up talking about some of the ideas that we were pursuing on healthcare reform. And this one in particular, I think, piqued his interest. And we started engaging in it between the two of us, and then on a staff level. We filed ours in January as part of our budget submission. As I mentioned in my testimony, we filed it previously in the legislative session before the pandemic began. I don't think there's an inherent benefit to having two states doing this as opposed to one. What I would say is I think the idea is a sound one, and if it's one that other states were interested in pursuing, we'd be happy to talk to them about it as well. And obviously, if it's something that folks at the federal level want to talk about, we'd be all in on those conversations too. I do think some of the stuff that's kicking around, basically saying that our drug pricing should look like Canada's, doesn't make a lot of sense to me for a whole bunch of reasons. And I'm much happier with a proposal like this one that creates predictability and reliability for people, especially around those medications that have been in the market for a long time.
I just add, Sue, that I had just been elected. I was driving down the Merritt Parkway with Andy, and the first call I got was a guy named Charlie who said, congratulations, what are we going to do about drug pricing together? And that was Charlie Baker. And I think he's too modest. I think Massachusetts has really taken the lead on this. I'm an old cable TV guy, so I'm happy to have Charlie take the lead on this, work together. I think together we can make a difference and show the rest of the country how we can make drug pricing a lot more predictable for some folks who need it.
Great, thank you.
Jessica Bartlett, and unfortunately this is our time for our last question. So Jessica Bartlett.
Hopefully I can make this a multi-part question if you'll allow me. The first is, where will the penalty go? Maybe that was addressed in Connecticut. I don't know if it was the same for Massachusetts. Who will collect this penalty? And is this a bill that's been filed? What's the process to enact this in Massachusetts specifically, but also Connecticut?
Hey, Lauren, you want to take a crack at that one?
Sure. So in the most recent House 1 budget proposal that included this language, we are proposing to direct the revenues from this penalty into the a revised community hospital and community health center investment trust fund. So you may be familiar with the current CHRTF. We're revising that, so it will go out and be used for expenditures for community hospitals, community health centers, serving some of our most vulnerable residents. Can you just repeat the second part of the question?
Sure. So you mentioned this is part of the House 1 budget. So what's the process kind of moving forward in the state?
So we will see. The legislature is anticipated to take up the budget in the next couple of months, and hopefully we will have our FY 2022 GAA at some point this summer.
Thank you.
So I think I can answer for Connecticut on behalf of the governor. So the penalty, if there is a penalty, and I just want to back up and say, we hope that the companies will limit their price increases under the legislation. We're hopeful that that's the path that's taken rather than the collection of penalties, but should penalties be assessed, it would be collected by DRS, our Department of Revenue Services, and deposited in the covered Connecticut account that the governor just spoke about before. That would help people access insurance in a more affordable manner. The bill in which this provision is contained also contains the covered Connecticut program, and it is House Bill 6447. It is a governor's bill, and it has come out of committee in a bipartisan fashion and is on the floor of the legislature.
All right, we have time for some final words. We'll start with Governor Baker, then we'll go to Governor Lamont.
First of all, I just want to thank folks for tuning into this, and I want to thank Governor Lamont and his team for working with us on it. I certainly think that as we think about all the issues associated with healthcare generally, we need to continue to focus on ones where we can create opportunities for people to benefit from all the terrific innovation and creativity and skill sets that people in our pharmaceutical and biotech industry bring to this table and to these tasks. But at the same time, we need to give people some kind of predictability around the stuff that's really been in the market for a long time. And I think in many ways, this proposal is our way of trying to achieve both of those objectives. And I look forward to working with our legislature on it and continuing to engage with Governor Lamont and others who may be interested in this in their states as well.
I just add that governors need predictability when we're putting together our budgets. Working families and small business need that same predictability. Carolina and Jay, thank you for sharing your story with us. That's why Charlie and I are doing this. You remind us every day how important it is. And Charlie, that haircut looks really good on you. Thanks, everybody.
Thanks a lot.